Hello, I'm Dr. Arrington, and I'm not really a doctor, but I'm playing one for this presentation.
And I'm Nurse Manley, and I'm not really a nurse or a woman, but I'm playing one for this presentation.
What is an ACO, and what does being part of an ACO potentially mean to radiology departments? In this presentation, we will define the basics of an ACO and discuss how a healthcare organization can become one. We will discuss why a healthcare organization might want to become an ACO and how an ACO differs from the traditional healthcare models. We will define and discuss population health. And lastly, we will explore the financial impacts to radiology departments and what they can do to be successful in the ACO system. What is an ACO, and how can a healthcare organization become one? ACO stands for Accountable Care Organization. An ACO is a network of doctors and hospitals that share the financial and medical responsibilities for patients. The main goal of the ACO is to provide coordinated patient care and reduce unnecessary healthcare spending. Under the ACA, Medicare and many private insurers have established ACOs throughout the United States. In today's healthcare system, the patient is usually responsible for coordinating his or her own healthcare. Oftentimes, the patient might see a primary care physician, a gastroenterologist, and a surgeon, all for the same diagnosis. But these providers don't always communicate with each other, leading to repetitive testing or conflicting prescription medications. This isn't good for the patient, and it also leads to wasteful spending. Let's take, for example, a patient who is diagnosed with breast cancer. Initially, the diagnosis could be suspected by the primary care physician who feels a lump during a routine breast exam. A routine mammogram is ordered, and the patient is scheduled for the exam at the Women's Imaging Center. If the findings are inconclusive, the patient is then sent for a biopsy performed by a radiologist. The biopsy is then sent to a pathologist at another medical facility who confirms the biopsy is malignant. The patient is then referred to a breast surgeon by her primary care physician. The breast surgeon removes the lump, and the patient is sent to a medical oncologist for chemotherapy treatment. Additionally, a radiation oncologist may provide radiation therapy, if indicated, at an outpatient cancer treatment center. By the end of her course of treatment, the patient has seen 6 different physicians at various medical facilities. At each appointment, the patient is responsible for providing her medical records, x-rays and scans, and lab and pathology reports. In many cases, physicians will not rely on images or lab results from other facilities, and will order duplicate and often unnecessary exams at their own facility. In this example, not only is the patient faced with cancer treatment and recovery, she is also faced with coordinating and managing her own health care. An ACO brings coordination to the patient's medical care. Physicians, hospitals, imaging services, pharmacies, and surgeons all work together to share information to provide the best, most cost-effective health care for the patient. In return, ACOs that save Medicare money receive an incentive of that cost savings, if the organization can show they're doing a good job keeping patients healthier. Why is there a need for an ACO, you might ask? Lawmakers, and looking at ways to reduce the national deficit, zeroed in on Medicare. The costs of caring for elderly and disabled Americans is expected to soar as the baby boomer generation reaches retirement age. In response, the Medicare Shared Savings Program was created. In this program, ACOs keep providers jointly accountable for the health care of their patients, in turn leading to financial incentives and saving Medicare money by avoiding unnecessary tests and procedures. Under the Affordable Care Act, a healthcare system that seeks to become an ACO must manage the healthcare needs of a minimum of 5,000 Medicare recipients for at least 3 years. Each ACO must create a governing body that represents ACO providers and Medicare beneficiaries. An ACO facility is required to be responsible for routine self-assessment, monitoring, and reporting of the care it delivers to Medicare beneficiaries. And they must use that information to continually improve care. A prospective Medicare ACO must then complete an application, providing all information requested by the Centers for Medicare and Medicaid Services, to include how the ACO plans to achieve the goal of delivering high-quality care and lower the growth of expenditures to its Medicare beneficiaries. If approved, the ACO must sign a contract with CMS to participate in the Shared Savings Program for a period of 3 years. Why become an ACO? And how does it differ from traditional models we see today? Because accountable care organizations play an integral role in aligning incentives for providers in care delivery, participating organizations are required to possess key competencies. Some of those competencies include leadership, organizational teamwork, IT infrastructure for population management, ability to manage financial risk, and resources for patient education and support. According to the American Hospital Association Research Synthesis Report, the first question a healthcare organization should pose when discussing the potential impact of becoming an ACO is, what is the role of the hospital in a new community environment that provides more efficient and effective healthcare? Health maintenance organizations, or HMOs, share some common variants with the concept of the ACO in that they both are attempts at improving overall patient healthcare delivery and payment. Although the primary goal of the HMO model was cost reduction, it sometimes came at the sacrifice of patient care. HMO members also suffered significant financial penalties if they left the network. ACOs recognize that healthcare markets have variations and that providers have the ability to accept new payment models. The HMO model suffered from criticism concerning its inadequate payment rates and high level of financial risk. The ACO has learned from these critiques and offers both public and private sector ACO providers a shared savings approach where providers receive consistent fee-for-service payments. But they also qualify to share in any savings that may result from cost reduction and meeting predetermined performance targets. Similarly, PCMHs, or patient-centered medical homes, share some commonalities with the ACO model. Both models promote the utilization of electronic health records, patient registries, and increased patient education to achieve the goal of coordinated and improved patient care. However, the PCMH model does not offer incentives for providers who work together to reduce costs and improve quality care. The PCMH also calls for the primary care provider to be responsible for coordinating the patient's care, which can be a challenging task if the primary providers do not have established relationships with other providers to achieve this. The ACO model addresses these shortcomings by fostering accountability for care and costs by offering joint payments to all providers involved in the Medicare beneficiary's care. Additionally, the ACO does not require that any particular provider take the primary responsibility for coordinating the patient's care. And unlike the PCMH model, the ACO offers a variety of payment methods, ranging from a traditional fee-for-service payment to full capitation. What is population health? The ACO isn't just focused on coordinated, streamlined healthcare for the patient, it is also focused on keeping patients healthy. The ACO switches the emphasis from simply treating illnesses to also improving and maintaining the health of the patient in an attempt to prevent avoidable illnesses and unnecessary care. Because of this, ACO and ACO providers must move to a population health management approach. Population health is defined as the healthcare outcomes of a group of individuals, including the distribution of such outcomes within the group. These groups can be geographic populations, like nations or communities. They can also be other groups, like employees, ethnic groups, disabled persons, or any other defined population group. Population health not only refers to the overall health of a population, but it also includes the distribution of health. It stands to reason that the overall health rates will be high if a majority of the population is healthy. The biggest challenge for physicians is that a majority of the patient's visit is typically concerned with treating acute problems, leaving little time for the physician to focus on preventative and chronic care needs. Now, however, ACO providers must shift their attention to the management of all patients in the practice, across the entire spectrum of health. That includes patients who are well as those with the most complex of conditions. This has proven to be a major transition for the ACO and ACO providers, particularly once the Patient Protection and Affordable Care Act extended healthcare coverage to an additional 32 million Americans. That, coupled with the aging and growth of the U.S. population, has increased the number of patients in need of chronic care management. Traditionally, healthcare models have sought to address the needs of patients who actively seek and participate in their healthcare. Those models were not designed to identify or engage the needs of disengaged members of the general population, or those who are not compliant with their recommended healthcare regimen. The ACO population health model seeks to change that by reaching across a broad healthcare spectrum to reach even those who are not cooperative or actively engaged. Their results still count in the ACO model. The U.S. Agency for Healthcare Research and Quality has formulated a concept titled Practice-Based Population Health, or PBPH. This concept refers to the responsibility of the primary care group and networks for the healthcare of their patient population. ACO performance measurement and quality reporting places the population to be managed under the PBPH as that of the entire healthcare organization, making this the level at which risk-based ACOs could potentially stand or fall financially. Clinically, though, the managed population consists of that of a particular primary care provider. This is the basis of the patient-centered medical home, which we discussed earlier, and is essentially the building block of the ACO. PBPH addresses the health needs of the entire population. Therefore, ACOs must actively reach out to every individual who has a relationship with an ACO physician, not just those who have recently been seen. Someone may be healthy today, but he or she could be sick tomorrow. The PBPH concept seeks to prevent or diminish those future illnesses, thereby benefiting the patient and the ACO. What are the financial impacts to radiology departments, and what can they do to be successful in an ACO system? From the very beginning, radiologists have been concerned that the ACO model could potentially limit the opportunity for their practices to retain their independence and also place them at an economic disadvantage. The growth of medical imaging has been on the decline in recent years for a number of different reasons. The most prominent including heightened concerns about radiation exposure to the public, cost effectiveness, and new initiatives involving appropriateness guidelines. These issues appear to have had a greater effect on medical imaging growth and diminishing revenues than an ACO participation. Institutions participating in the Centers for Medicare and Medicaid Services PGPD test model did not demonstrate any initial reduction in imaging that could be directly related to the ACO model. Despite the initial concerns from radiologists, it does not appear that ACOs will have any direct negative effects on the practice of medical imaging. Current strategies focus specifically on coordinated patient care and disease management, and do not intend to minimize the use of clinical services, such as radiology. Medical imaging has the ability to make the referring physician more efficient, and with the goal of the ACO to reduce reimbursements for patient visits, greater emphasis has been placed on clinical turnouts. Imaging works to the advantage of the referring physician in that it allows for a more accurate diagnosis while spending less time with the patient. Referring physicians and emergency rooms can increase throughput as well as their diagnostic abilities by taking greater advantage of medically indicated diagnostic imaging exams. Historically, health systems have often considered radiology departments as simply windows to look inside the body, and radiologists have been treated as a set of well-trained eyes tasked with interpreting images for ordering physicians. But under the ACO, the radiology department has been asked to take on a greater role in patient care coordination. Radiologists have become an active part of the discussion, as well as providing decision support to the referring physician. Consulting on imaging appropriateness and providing feedback is a key component of radiology participation. Radiology departments can ensure their future within the ACO model and add value by participating in and providing utilization management. The importance of informatics to managing population health and accomplishing the goals of the ACO cannot be understated. Radiology departments will need to fully integrate into the EMR system to be successful within the ACO system. Reimbursement is largely tied to quality performance. Therefore, radiology departments and radiologists will be tasked with following the same quality care objectives set forth by the ACO. While the specific benefits to the radiology department within the ACO model seem few, so are the disadvantages. Clearly, one of the greatest benefits for radiology departments continues to be supporting the ACO by working with referring physicians to control imaging utilization, ensuring image appropriateness, and helping to reduce costs. This will affect overall quality within the ACO and provide radiology with a solid seat at the table in the future of the ACO. Thank you for taking the time to watch this presentation today on what is an ACO and what does being part of an ACO mean potentially to radiology departments. I hope you found it informative. This is Dr. Arrington, but not really Dr. Arrington.
Yeah, my patients die before they can pay. Like a surgeon, hey, cutting for the very first time. Like a surgeon.